Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the Ultimate USMLE Step 1 Review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 10 of the Neurology chapter. We're going to start by talking about neuromuscular blockade. Neuromuscular blocking drugs inhibit neuron transmission to muscles by blocking postsynaptic nicotinic acetylcholine, or ACH, receptors. Clinically, they are used to produce paralysis, which aids in intubation for mechanical ventilation. They are generally classified as non-depolarizing or depolarizing neuromuscular blocking drugs based on whether or not they depolarize the motor end plate. They're reviewed in more detail in Table 13-12, which we'll review now. The non-depolarizing include atracurium, pancuronium, rocuronium, and cisatracuronium. The drug names generally end in curonium or curium. These are competitive antagonists that can be reversed with increase in acetylcholine by acetylcholinease inhibitor drugs, or ACHEIs, for example, neostigmine. They exhibit tetanic fade, which is a failure of muscles to maintain a fused tetany at high electrical stimulation frequencies. The depolarizing class includes succinylcholine. This is resistant to degradation by acetylcholinesterase, but it has a short duration because of metabolism by blood cholinesterase, which is also called pseudocholinesterase. This is a non-competitive antagonist with two phases. Phase 1, or the depolarizing phase, results in sudden muscle fasciculations and twitches followed by flaccidity. Phase 2, the desensitizing phase, this is less responsive to depolarization. After Phase 2, full neuromuscular blockade or paralysis is complete. ACHEI potentiates Phase 1, but can reverse Phase 2. It does not exhibit tetanic fade. A complication includes hyperkalemia caused by upregulation of receptors as a result of nerve damage or demyelinating disease. For example, spinal cord injury, multiple sclerosis, or chronic burns. All right, now we're going to talk about the pharmacologic treatment of other neurologic disorders, beginning with Parkinson's disease. In general, the treatment of Parkinson's disease involves increasing the amount of dopamine in relation to acetylcholine. Once pharmacotherapy has been exhausted, surgical therapies are available, such as deep brain stimulation. Table 13-13 provides an overview of pharmacotherapy for Parkinson's disease, and we're going to go through that in some detail as well. L-DOPA, or levodopa, and carbidopa are the first group of medications. The mechanism is that L-DOPA crosses the blood-brain barrier to increase brain dopamine. Carbidopa prevents peripheral conversion of L-DOPA to dopamine. Side effects include arrhythmias from peripheral conversion. There's an on effect, which equals dyskinesia, and there's an off effect, which results in akinesia. Other side effects include hallucinations and delusions at high dosage. And then some comments. The overdose treatment is pyridoxine, which increases the peripheral metabolism of these medications. A high-protein diet competes with L-DOPA. The next drug name is amantadine, which increases dopamine release. Side effects include ataxia and livedo reticularis, which is red-blue fishnet modeling in the skin. Some comments. These are good for the on effect, or dyskinesia. It's also an antiviral medication used to treat influenza. The next group of medications include bromocriptine, pergolide, pramipexole, and ropinirole. These medications agonize dopamine receptors. Side effects include somnolence, hallucinations, and compulsive gambling. These medications are good for the on effect. They increase dopamine activity without increasing concentration, so it allows for a lower carbidopa-levodopa dose. The next group of medications include selegiline and rasagiline. These are selective MAOB, or monoamine oxidase B inhibitors. Side effects include hypertensive crisis at high dosage. These medications are good for the off effect. Rasagiline does not have sympathomimetic action, unlike selegiline. The next group is talcapone and entacapone. These are COMT inhibitors, where COMT is catechol O methyltransferase. Side effects include central effects and hepatotoxicity. Entacapone does not cross the blood-brain barrier, so it produces less central effects. The next group is benztropine, biperidine, and trihexyphenidyl. These are antimuscarinic agents, and as side effects, they have anticholinergic toxicities. They are used in drug-induced Parkinson's disease. They improve tremor and rigidity, but not bradykinesia. The next disease to talk about is Alzheimer's disease. Current therapy is aimed at counteracting the reduction in cholinergic activity and excitotoxicity of glutamate seen in Alzheimer's disease. In addition to pharmacologic therapy, caregiving and psychosocial intervention needs to be addressed. Pharmacologic therapy is reviewed in more detail in Table 13-14. Let's start with the acetylcholinease inhibitors, which include donepezil, rivastigmine, galantamine, and tacrin. The mechanism is to reduce the rate of acetylcholine breakdown, thus increasing acetylcholine concentration. Side effects include nausea and vomiting because of cholinergic excess. The next medication is memantine, which is a non-competitive NMDA receptor antagonist. Side effects include hallucinations, confusion, and dizziness. Now let's talk about Huntington disease. The symptomatic management of chorea and optimizing quality of life are the main two goals. Chorea is treated in a stepwise system, starting with tetrabenzene and then moving to atypical neuroleptics, typical neuroleptics, and eventually a combination of tetrabenzene and a neuroleptic. Tetrabenzene and reserpine are drugs used in the treatment of Huntington disease. The mechanism is that they are VMAT inhibitors. VMAT is vesicular monoamine transporter. So they promote dopamine degradation. Side effects are similar to antipsychotic side effects, such as akathisia, depression, dizziness, and Parkinsonism. But these medications do not cause tardive dyskinesia. Now let's talk about multiple sclerosis, which is outlined in detail in Table 13-16. First medication is interferon beta. This medication has anti-inflammatory properties and improves blood-brain barrier integrity. Side effects include flu-like symptoms and injection site reactions. Next is glatiramer acetate. This medication works by resembling myelin basic protein. It shifts pro-inflammatory Th1 cells to regulatory Th2 cells to suppress inflammatory response by substituting itself as a target of immune system attack. Side effects include injection site and injection reactions. It's the least likely to produce flu-like symptoms. Metoxantrone is a topoisomerase inhibitor generally used in cancer chemotherapy. Side effects include nausea, vomiting, hair loss, immunosuppression, and cardiomyopathy. The next medication is natalizumab. This is a monoclonal antibody against cellular adhesion molecules, which reduces influx into the CNS. Side effects include fatigue, allergic reactions, hepatotoxicity, and PML development. The next medication is fingolimod. This is a sphingosine analog. derived from fungus that modulates sphingosine 1 phosphate receptor to sequester lymphocytes in lymph nodes. Side effects include fatal infections, bradycardia, skin cancer, and hemorrhagic focal encephalitis. Now let's talk about headaches. The first-line treatment in acute attacks is typically NSAIDs, such as ibuprofen, naproxen, ketorolac, or aspirin. Triptans such as sumatriptan may also be used to treat acute migraines. These are often combined with antiemetics such as prochlorperazine, metoclopramide, or ondansetron. Medications used for migraine prophylaxis include tricyclic antidepressants such as amitriptyline or nortriptyline, anti-epileptics such as valproic acid, difalproex, or topiramate, beta blockers such as propranolol, and calcium channel blockers such as verapamil. In terms of talking about these medications, the triptans, the mechanism is serotonin 5-HT agonists. They cause vasoconstriction and subsequent inhibition of pro-inflammatory neuropeptides. They're used to treat acute migraines and cluster headaches, although they're second line for cluster headaches. Side effects include the risk of coronary vasospasm causing myocardial infarction in coronary artery disease patients. They can also result in serotonin syndrome and are contraindicated in pregnancy. The ergotamines are similar to triptans, but act at various receptors, including 5-HT, D2, and norepinephrine. So they have more severe side effects than triptans and thus are rarely used. When they are used, they're used to treat acute migraines. Side effects include retroperitoneal fibrosis, which is the most serious side effects, and this can lead to hydronephrosis or varicocele. Now finally, let's talk about stroke. Once a thrombus or blood clot occurs in an ischemic stroke, removing the blockage by mechanically removing it with thrombectomy or by pharmacologic thrombolysis, clot busting, with TPA are the two definitive therapies available. TPA catalyzes the conversion of plasminogen to plasmin, which degrades fibrin clots. Therefore, TPA activates the body's own clot degradation system. Before giving TPA, a list of inclusion and exclusion criteria is reviewed, and the risks and benefits are discussed with the patient and family. Multiple contraindications exist and include severe hypertension, recent bleeding, such as GI bleeding or intracranial bleeding, as well as recent surgery. To be most effective, TPA should be given as early as possible. Generally, it is given within 3 hours of the start of neurologic symptoms, but this window can be extended to 4.5 hours depending on certain patient characteristics, such as age less than 80, no history of stroke or diabetes, and the patient not taking anticoagulant medications. Once given, close observation is done to evaluate for hemorrhage, especially intracerebral hemorrhage. That's the end of this chapter. I encourage you to take a look at the book for the review questions that are provided.